Today I'm going to talk about respiratory failure. Respiratory failures are of two types, both type 1 and type 2. So I'm going to discuss both together. Uh, Before that, I think you know all this anatomy, that the gas exchange occur at the alveolar level. Alveoli, this is the cross section of the alveoli which you are seeing here, and these are the blood vessel. An important concept which I want to explain to you people is that usually the ventilation, that is the air inside the alveoli, and the perfusion, that is the blood in the capillaries, are well matched. There are a lot of conditions in which there is a mismatch between the uh, ventilation and perfusion, and that can cause into respiratory failure. Let's assume that this alveoli have got tiny amount of fluids here. So these ventilation will be less if the alveoli are totally empty compared to that. So if there is a little amount of fluid here inside, this will be called as decrease in the ventilation, one of the things, but the perfusion will remain the same. So this will be that there is a mismatch between ventilation and perfusion. The perfusion is there, but the ventilation is less. So mismatch. Similarly, if due to any reason these capillaries get blocked, like pulmonary embolism, if the blood is not coming into the capillaries, so there will be a ventilation, but there will be no perfusion. So when we talk further, there will be this word coming in: ventilation, perfusion, mismatch. And another concept which you have to understand from here, that if the whole alveoli are filled with the fluid, then there will be no air coming into the alveoli. So the blood which comes here will hardly receive any oxygenation. Even the carbon dioxide will not go out, and the blood will shunt out from the arteries to the venous without getting any oxygen. So this is called AV shunting. So anything which causes mismatch of alveolar ventilation will, in an advanced form, causes uh, shunting of the blood. Now, when there is an alveolar mismatch, alveolar ventilation perfusion mismatch, I mean, if it is in a small area of lung, what will happen is that the respiration will increase, and the healthier areas of the lung will compensate for less amount of ventilation here. So the effect will not be so much. But if the whole lung, both the lungs are involved, then the blood will totally shunt out without getting any oxygen. So these ventilation perfusion mismatch in an advanced form causes shunting of the blood inside the lungs. Now, we know that respiration is being controlled basically by three centers. One is the higher center, which is under voluntary control, that you can hold your breath for certain length of time. But this hold is a very short period of time. So this is a voluntary control, which is in the cortex. Then there is an center of respiration in the hypothalamus, which is basically responsible to your emotional changes and due to pain that respond very rapidly. So if you are under anxiety, when your exams are near, you start increasing your respiratory rate involuntarily without knowing it. This is called hyperventilation. When there is a sad news coming in and suddenly you start panicking and your respiration increases, this is because of this center. Now, there is another center lower down, which is in the medulla and in the pons, and this is very sensitive. This is very sensitive to change in carbon dioxide or pH level. So any condition which causes acidosis or increase in H ion in the body causing acidosis, the respiratory centers stimulate, so that the more the carbon dioxide is being eliminated from the body to cause buffering of that. Carbon dioxide in other form is a acidic thing. So to remove the acid from the body, you will try to compensate for any increase in the any decrease in the pH. So whenever there is a decrease in pH, the respiratory rate get stimulated so that the more carbon dioxide is being removed. Similarly, any condition in which the carbon dioxide is increased, you know that carbon dioxide dissolve in water and form carbonic acid. So carbonic acid is an acid. So either increase in carbon dioxide will cause respiratory acidosis, And if there is a metabolic acidosis, the H ion increases and the respiration stimulates, remove the carbon dioxide, but there will be less amount of carbon dioxide. This is called compensation. So remember that the respiration is very, very sensitive to pH and carbon dioxide. Body wants to maintain carbon dioxide and pH in a very small range. You know that the normal value of pH is 7.45 to 7.35. Just less than a 1% change causes significant changes in your body. So the pH is very tightly controlled in your body. Now, there are receptors near your carotid and the bifurcation of the carotid and near arch of aorta, and these are called peripheral chemoreceptors, and they are the one which are responsible for change. Similarly, due to any reason this nerve supply is damaged, there is a central also. So if the CSF carbon dioxide increases or the pH increases, then the respiratory center gets stimulated. The receptors for stimulating the respiratory medulla directly is also in the joints and in the muscles. It is also in the lungs and airways. So when your muscles are moving, when you are exercising, then directly they can stimulate the respiratory center without even making any changes in the pH or carbon dioxide or causing any hypoxia. So your respiratory rate automatically increases. Similarly, due to any reason, if you inhale any irritants, the receptors are in the airways, they get stimulated and your respiration increases and you can have bouts of coughing. Any stretch on the lung or distortion of the lung due to fibrosis also irritate these receptors and causes coughing. So coughing and increasing in the respiratory rate. So this is how the respiration is being controlled. Now again, the same thing which I wanted to discuss, the alveolar, because further when we discuss the respiratory failure, this is an important concept that normally there is a ventilation and perfusion matching. Oxygen comes in the alveoli, diffuses into the red cells, carbon dioxide comes out of the red cells and goes into the alveoli. So any mismatch between ventilation and the perfusion causes an increase in decrease in the oxygenation. Carbon dioxide is 20 times more diffusible as compared to oxygen. So even then, carbon dioxide is usually not affected by any alveolar ventilation perfusion mismatch. Similarly, this is called alveolar capillary membrane. This is a capillary, this is the alveoli membrane. So both together is called alveolar capillary membrane. Diffusion occurs through this. There is no gradient across it. So it's just movement of the oxygen and carbon dioxide. Similarly, any condition which causes thickening of this membrane, fibrosis of this membrane will impair the oxygen diffusion. But carbon dioxide 20 times more diffusible, so it will diffuse out. So usually in these conditions, VQE mismatch, alveolar ventilation mismatch, or alveolar capillary membrane thickening, usually the oxygenation is affected, not the carbon dioxide is affected. So there causes type 1 respiratory failure. So now coming to what is respiratory failure. Respiratory failure is a syndrome that is the constellation of the different signs and symptoms. Basically, when your respiratory apparatus fail to maintain the normal gas exchange. So you will either fail in your oxygenation or removal of carbon dioxide, or it may be both. So this is called respiratory failure. Now we classify respiratory failure into two types. One is called hypoxemic failure, also known as type 1 respiratory failure, or hypercapnic, which is called type 2 respiratory failure. So in hypoxic failure, there will be always low PO2. That is, the partial pressure of oxygen will be low in your blood. Carbon dioxide will be low or normal, but it will not be raised. Again, because whenever there is a hypoxia, respiratory center stimulates, and the healthy portion of that compensate for the low oxygen, and more carbon dioxide is being removed. So only the oxygenation is being affected. But in type 2 respiratory failure, we will discuss the causes, then you will know why type 2 respiratory failure occurs. There, the carbon dioxide is basically the movement of the carbon dioxide is impaired, and usually it is associated with low oxygen. So when both the things are low, it is type 2 respiratory failure. When only oxygen, it is type 1 respiratory failure. These are the normal blood gases values. You should remember that pH is 7.35 and between 7.35 to 7.45. So just zero point 0.1 is the range. Little up or little down can cause a problem. So this should be remembered that body likes to control the pH very tightly because the cell functions is going to impaired just with slight acidosis or slight alkalosis. PO2 is between 75 to 100 and PCO2 35 to 45. Bicarb is 22 to 26. So these are the normal values which you should remember, because unless you know that, you will not be able to do the ABGs or know what is the respiratory failure. So type 1 respiratory failure when the partial pressure of oxygen is less than 60 millimeter of mercury at room air, when you are breathing room air. Carbon dioxide will be normal or low. Type 2 respiratory failure, carbon dioxide is greater than 45. Either it's written 50, but usually even above 45 is taken as type 2 respiratory failure. PO2 usually remains normal or sometimes maybe low. So most of the time it is low, but sometimes it can be normal. So it is just the carbon dioxide which gets eliminated in type 2 respiratory failure, but most of the cases the oxygen is also low. Now, why we have type 1 respiratory failure or low oxygen in your blood? These are the 5 basic mechanisms which causes low oxygen in your blood. First of all, we will give you the example of each one is a low inhaled oxygenation. For instance, if your partial pressure of oxygen in the air is reduced, if you go to the high altitudes, you will have less oxygen there, so you will have an hypoxemia. Particularly if you climb up high mountains suddenly, if you are not acclimatized to that, you can get a severe hypoxia and mountain sickness and all these things. But if you are used to it, then your body adapts to that hypoxic low oxygen. Another thing is the VQ mismatch, as I was trying to explain you, that is the problem with either ventilation or the perfusion. This is Q stand for perfusion. So in any case, when there is a problem, this is called mismatch between ventilation and perfusion. Now, if this is in an advanced form, benefit both the almost lung or major part of both lungs, this will be resulting in left to right shunt. That is no oxygenation, and there will be total shunting from the artery to the venous without getting any oxygen. When there is a intracardiac defects, that is also a right to left shunt. For instance, if you have an ASD, VSD, that is also a shunt. But in the lung, this is basically advanced form of VQ mismatch. Then I was trying to explain you that there is an alveolo-capillary membrane. If that gets thickened, right, that is also responsible for impairment of the transfer of oxygen into the blood and causes hypoxemia. Lastly, alveolar hypoventilation. Alveolar hypoventilation is basically when less amount of oxygen is coming in the alveoli, alveolar hypoventilation. Basically, it's the tidal volume, respiratory rate divided by dead space. So if the dead space due to any reason increases, the alveolar ventilation reduces. If due to any reason the respiratory rate decreases or the amount of air which is going into the tidal volume reduces, all these causes alveolar hypoventilation. You can assume that for more practical purposes, less amount of air is moving in and out of the lung is alveolar hypoventilation. So now taking the example of each and everything, as I said to you, low partial pressure of oxygen, high altitude, you know that, and high mountains, we know that. Right to left shunt, whenever there is a right to, it can be a mechanical shunt, like in cases of Eisenmenger, ASD, VSD, all these cases, the blood from the right lung goes into the left lung without getting any oxygen from the lungs. So this is a right to left shunt. Sometimes the blood vessels, there is an arteriovenous malformation in the lung, like in cirrhosis of the liver. That is also a right to left shunt. But most of the time, when there is a ventilation perfusion mismatch and it is affecting most of the lung, then there is a shunt. Now, ventilation perfusion mismatch, again, either there is a ventilation problem or there is a perfusion problem. Then there could be different reasons like mucus plugging, pulmonary edema, the alveoli filled with the fluid, pulmonary embolism where no blood is coming into the lungs, major pulmonary embolism. So this is causing VQ mismatch. And finally, impaired diffusion, that is a thickening of the alveolo-capillary membrane. This is happens in one of the very common disease, which is called ILD, interstitial diffuse interstitial lung disease. That is the interstitium. That is the interstitium is the same thing between the alveolar and the capillary membrane. The interstitium which is there, it gets thickened there. So the movement of the oxygen from the alveoli to the airs to the capillaries get impaired. So this is called impaired diffusion. And classical example is interstitial lung fibrosis or diffuse interstitial lung disease, ILD, diffuse interstitial lung disease. Now, whenever you see hypoxia or hypoxemic failure with normal carbon dioxide, the first thing you have to do is to find out AA gradient. That is the gradient across the alveoli and in the blood vessel. So this is called alveolar capillary, this is called AA gradient. That is the gradient across the oxygen in the alveoli and the oxygen in the blood. Normally this gradient is about 12 and it may slightly increases with the age. So this PaO2 is the alveolar oxygen, P small a oxygen is the arterial oxygen. The difference between the two is called alveolar arterial gradient. So this gradient is around 12 or 12 to 16. And how do we calculate this? You should remember this formula whenever you go to the ward, and if you find anybody has got low oxygen with normal carbon dioxide, this formula gives you a very good idea what could be the possible cause of hypoxia. So 150 is the partial pressure of water in the atmosphere minus carbon dioxide, which you can easily calculate from your blood gases, divided by respiratory quotient, which is 0.8, and this is PaO2, yani arterial oxygen. So all this is available from the blood gases if the patient is on normal room air. By putting these values in there, you can calculate the AA gradient. Is it normal or is it raised? I mean, there's not any condition it will be low. There is raised or normal, and it will be very useful. So normal AA gradient is age divided by 4 plus 4. So this is the usual formula, but if you want to remember it, it is somewhere around 12 to 14 or 15. With age, it may increases up to 20. So these are the examples and how we try to differentiate between these different things. By giving them oxygen, you will know which type it is. I think it's much more clear in this diagram how to differentiate various causes of hypoxemia. So let's say one of the cause which I told you is low oxygen in the atmosphere, high altitudes. So if you give them, here the AA gradient will be normal because there is no defect in the ventilation or perfusion, so AA gradient will be normal. So first thing, hypoxia, you calculate AA gradient. If it is normal, then these two causes should be remembered. If it is increased, then these three causes have to be remembered. So AA gradient, normal. Two things, FiO2 is reduced atmospheric, or there is a hypoventilation. Hypoventilation can occur due to a number of causes, and hypoventilation is usually associated with increased carbon dioxide. So you can easily recognize that if the AA gradient is normal, then either it is impaired, partial pressure of oxygen in the atmosphere is low. But for instance, if a person goes deep down into a sewerage canal, there may be low oxygen. If when they go for a scuba diving, when they go on very high altitude, they take oxygen to supplement that oxygen to maintain their FiO2. All right. So carbon dioxide here is normal. If the A gradient is normal, but carbon dioxide is elevated, then these are the causes which you should be keeping in mind. CNS depression, narcotic, obesity, muscular weakness, all these causes. Now the problem is here, when we have got an increased A gradient, then three causes should be considered. VQ mismatch, diffusion impairment, and shunt. VQ mismatch, as I told you, is the minor form of shunting. So for instance, this is the alveoli. There can be two possibilities. Ventilation is normal, but the perfusion is reduced because there is a pulmonary embolism blocking the artery. So if there is a pulmonary embolism, there is a reduced amount of reduced amount of perfusion, but the ventilation is normal. So this is also a cause of ventilation perfusion mismatch. So if this is normal, this is reduced, so this will be an increased ventilation VQ will be increased. So this is one of the causes of increased ventilation perfusion mismatch. That is pulmonary embolism. Where is the cursor? There it is. So there is ventilation, but there is no perfusion. Now, similarly, if there is some little bit of fluid inside these alveoli, some of the alveoli are filled with, and some are normal, there will be reduced ventilation, but the perfusion is normal. So the ratio will be reduced. So these are the causes. Now, if you give oxygen, high concentration oxygen, in case of VQ mismatch, you will be able to improve the oxygenation significantly. So what usually we do in the clinical practice, we see that there is an hypoxemia. Now we don't know out of these three which one is the cause. Give them 100% oxygen. If there is an improvement, let's say partial pressure of oxygen in the ABGs was 50 millimeters of mercury, and if you give them 100% oxygen, after a few hours, you repeat the blood gases, if there is a significant improvement, you can say that this is a VQ mismatch. But if there is no improvement, then this is a shunting, because either all the alveoli are filled with the fluid, therefore there will be no ventilation. Ventilation is being crossed like this, perfusion is there. Or if there is a major embolism and there is no ventilation, there will be no perfusion and ventilation will be there. So when there is a total imbalance between ventilation and perfusion, that is a shunting, and shunting will not improve no matter how much oxygen you can give to them. For instance, if there is an ASD or VSD major, all the blood from the right ventricle is going to the left ventricle without getting into the lungs. So no matter how much oxygen you give them, it will not improve. So advanced form of VQ mismatch is shunting. Now, coming to the type 2 respiratory failure, remember that anything which affects the respiratory rate right from the center down to the respiratory muscles will cause impairment or alveolar hypoventilation. As I said to you, it depends upon the minute ventilation, that is the amount of air which is moving in and out of the lung. So if you are drug overdose, if you have a brainstem lesion, if you have a stroke, your respiratory center is depressed, so your respiratory rate will reduce, less amount of air is going in and out of the lung. Similarly, the nerves which are bringing the stimulus from the respiratory center to your muscles, respiratory muscles, to increase to make your chest move, like motor neuron disease, Guillain-Barré syndrome, neuromuscular junction disorder like myasthenia gravis, myopathies where muscles are actually damaged or muscles are weak. Then the movement of the air, because your chest cage is dependent upon not only on your respiratory center, but also the stimulus which is coming down from your respiratory center to the chest muscles. Or any problem anywhere will affect the movement of your chest. When it affects the movement of the chest, there is an alveolar hypoventilation. The causes are either respiratory center get depressed, if there is the nerve which are bringing the stimulus to the muscles, if the junction between the muscle and the nerve is impaired, if the muscles themselves are impaired, and sometimes pulmonary condition like COPD or bronchiectasis. Now, somehow the other, in patients who have got COPD or lung, basically COPD, their respiratory center is lazy. So even if there is a hypoxemia, if there is a reduced pH, it doesn't get stimulated enough. So they remain into alveolar hypoventilation. And that's why they will have a rise in their carbon dioxide. Oxygen will be normal or low. And finally, the chest wall movement, the chest wall deformities, like flail chest, very obese person, because if there is a big chest, a lot of fat over your chest, the movement will be impaired. Kyphoscoliosis, again, you know that there will be kyphoscoliosis, like this sort of thing. The movement will not be there in the lungs, so there will be less amount of air coming into the lungs. And there will be alveolar hypoventilation. And alveolar hyperventilation, we know that it causes type 2 respiratory failure. Not only it will affect the oxygenation, but at the same time, the carbon dioxide removal is also being impaired. So there will be rise in the carbon dioxide and low oxygenation. Now, when you examine, from the history, I mean, you can find a clue what is the cause. These are the symptoms and signs of type 2 respiratory failure, like trachepnea, breath apnea, gasping, pursing of the lips, tightness in the chest. These are all signs and symptoms which you occur. Now, management of respiratory failure, first thing is to maintain the airway, circulation, and breathing. If there is a low oxygen, if there is a type 1 respiratory failure, you give them oxygenation. But remember that in type 2 respiratory failure, particularly if there is due to COPD, where there is an increase in carbon dioxide, you should be very careful in giving oxygen to them, because they are dependent on their hypoxic drive. They maintain their breathing because they have low oxygen, because I told you that their respiratory center is lazy. So if you remove the hypoxic drive, you give them more oxygen, so their respiratory rate will further reduce, and there will be further accumulation of the carbon dioxide in these patients. So remember that when you go to the ward, patient if have got a cigarette smoking, biomass exposure, they will have COPD, and this will have type 2 respiratory failure. In type 2 respiratory failure, most of the time, when it is due to lung condition, not because of the muscle, not because of the CNS depression, you should be giving low oxygen to them, otherwise their carbon dioxide will increase. So how do we manage them? Not by giving more oxygen, but by giving them non-invasive ventilation, that is giving the air, the more amount of air, by putting a mask on their face, so that they can compensate for alveolar ventilation. This is the different gadgets through which we give oxygen, nasal cannula. Now remember that 4 to 5 liters of oxygen can be given with nasal cannula. We have seen in the ward 15 liters of oxygen, and they are having a nasal cannula. So there is no point in giving such high oxygen, because it will not deliver that oxygen. Mass, it gives slightly more. If you have to give calculated amount of oxygen, how much, you have to attach these different pieces at this end. So it is written here 24, 28% oxygen, 40%, 35%, 40%, 50%, and 60%. So depending upon which one you use, you give more amount of oxygen and graded oxygen, that you know what you are giving. And how this happens, because of the size of these aperture. So if the for instance, this is 24% and this is 40%, the aperture size will be low, so less amount of air will be coming, more oxygen is going into the substance. And this is called non-rebreathing bag. So there is a big collection of oxygen, the oxygen is coming, it goes here, and from there he is having high concentration oxygen, usually around 60 to 80%. So this is that. This is something new, high flow nasal cannula, or nasal cannula, in which almost 100% of oxygen can be given through this machine. This is a little more technical, but if you want to see that, this is when you have to need a very high concentration of oxygen. Like these days, we are giving this to the COVID patients who are hypoxic, before putting them on ventilator, this machine can be used to deliver maximum amount of oxygen to them, 100% oxygen. The flow through this is almost 60 liter per minute. Usually in the ward, when you go, there is, I mean, they are giving 15 liters of oxygen. But with this, it almost, with this 60 liter per minute oxygen goes in. So it's a very high flow oxygen to maintain a very high level of oxygen. These are the ventilators. These are called non-invasive ventilator, which is used in COPD patients to improve their oxygenation and to keep their carbon dioxide low. This is an invasive ventilator. When this fails, then you have to put them on this. With that, I stop here. Thank you very much.